Hello and welcome back to Venus Rising. I am so excited to be talking with today's guest, Dr. Theresa Morris. Dr. Morris is a professor of sociology and women's and gender studies and coordinator of the Women's and Gender Studies program at Texas A&M University, where she teaches undergraduate and graduate courses in methods, gender, organization, medical sociology, and reproduction. Dr. Morris also conducts research on gender, reproduction, and birth. Her first book, Cut It Out, The C-Section Epidemic in America, was positively reviewed in several venues, including the New York Times. And her second book, Healthcare in Crisis, Hospitals, Nurses, and the Consequences of Policy Change, received honorable mention in the 2019 Adele E. Clarke Book Award. Theresa, thank you so much for joining us today. I am so excited to talk to you about your work, your research, and your books.
Well, thank you for asking me to talk about these, the research and the books. I love being able to share research in a way that, I go beyond my students and academics who might read the research. So thank you for this invitation. It's wonderful.
Of course, I'm glad we were able to connect. Everyone is so busy these days and there's so much going on. And so thank you. Before we begin talking about your book, and I have both of them here, both great books. I can't wait to talk about those. But before we begin, where did your passion for teaching sociology and specifically like medical and gender studies and reproduction come from? Why was that something you're interested in?
Right. Well, so I'll tell you how I became a sociologist and college professor, and then how I studied reproduction, because they're kind of two different paths, I would say. So I was set on being an attorney when I went to be an undergraduate. I was really very intrigued by helping people who I felt like didn't have power in our society. I thought the law was the way to do that. If I could have law, I could help people who were, marginalized or didn't have access to, to some of the resources in society, that I could help them with that. That was kind of my way of thinking about things. And it was when I took a sociology course that I realized that sociology at the heart of the discipline is interested in power and inequality, and really focuses on how the structures in society really can influence our ability to be successful, that it's not just about, my efforts, which clearly have some, an effect on one's success, but also, your characteristics that you have no control over, your gender, your race, your family of origin, can have huge effects on your opportunities to be successful. And that really resonated with me, that idea that, people can work really hard and not have the same ability to be successful, even though they're working, everyone is working, with the same rigor and the same motivation. And so that really spoke to me. And so I became a sociology major because I think I was really interested in that, and took classes in race and in class and in gender. And then I think when I was at the end of my undergraduate career and I was trying to think, would I go to law school or go to graduate school, I made the decision that I would go to graduate school and get a master's in sociology, which is a 2-year degree typically, and then decide if I wanted to go for a 3-year PhD or a 3-year law degree. And then I kind of forgot about becoming a lawyer once I went to graduate school. And so it's funny when I look back, I think you're so socialized into graduate school and getting a PhD. So I just continued on to get a PhD, kind of enjoying my time in graduate school, being a teaching assistant. So doing some kind of, grading, going to class, but not having to actually take full responsibility for teaching the class. And seeing that another way that I could help in society is to teach students about issues about power and inequality. And through that, to make change makers, right? So I was interested in students becoming knowledgeable about different types of inequality in society, and for them to take some kind of responsibility for changing that. And I really do think that we as social scientists can communicate these types of things to students and really make them more, even if they're not, kind of the change makers, I envision, right? They're engaged, people in society, they're engaged in their community. They can take a different kind of, I think, look at society, knowing that it's not just what we do, right? It's like there are things that we could change on the outside kind of structures in society that can help or hinder individuals. So anyway, so that's how I became a professor. And then I'll say that I was trained in organizations. You might have heard in your introduction to class in organizations. And because to me, organizations are very powerful in our society. So we all, when I teach organizations, I say, make a list for me of the organizations you have come in contact with today. And it's a bunch, right? I mean, like go to Starbucks or you're in school, right? There's your organization. It's just, I use my debit card, which is linked to a credit union or a bank.
Right.
Right. And so I was really interested in that. And I was interested in power and inequality. And so what I did my dissertation on was the banking industry in the United States. So I was interested in, I was interested in mergers and acquisitions, why they happen, what banks were the, kind of acquired versus acquiring. They were, they tended to be smaller banks and actually more successful. But it meant concentration of resources, banking resources, which can have effects on different groups in society. So I was really interested in that and was, going along publishing articles, looking at banks, looking at, the effective structure on lending policies when I became very interested in studying reproduction and birth. So
you have like done it all.
It's coming around. It's like coming around.
Awesome.
So I have two kids. Well, they're actually legal adults, both of them now. My son was 21. I had him right as I was finishing my dissertation. He was a surprise breech baby. So I thought he was head down. And I think he was head down until maybe a couple of days before I went into labor. I was very surprised that he was breech and had, I guess it was probably referred to as an emergency C-section, but it was, I went to the hospital, was going to have vaginal birth. They decided he was breech. And so I was quickly moved to a C-section. There was nothing, he was not unhealthy. My fetus was not unhealthy, right? Fetus before he was born, he was not unhealthy. He was not showing signs of distress. But they didn't have anyone who would deliver him vaginally. So I just experienced that as just, I would say somewhat traumatic. I think I didn't expect it. I prepared for vaginal birth, fully expecting that, and just felt like I didn't even have the words to say, can I deliver him vaginally? All I could think to say, because I didn't know he was breech, when I went into labor, I said, can you turn him? Can you flip him? And that would be an external Sabal version, right? Where you kind of like, right, move this, but I'm thinking your viewers might not, right? Like they kind of move the baby with their hands, they try to move the baby into a head down position. And what my OB said is, you're small, I'm a smallish person. He's big, he was 8.5 pounds. You're in labor, no. And I didn't think to say, can you deliver him vaginally? And I don't think they would have, but I really regretted that. Yeah. And I thought, why didn't I say that? And why didn't someone say, would you like to try? And so it really just struck me as, I guess I experienced it as something I didn't choose to do. Mm-hmm. And he had low blood sugar. He was a sick baby for a week. So that also, as a first baby, any baby, but especially first baby, can be very difficult. Yes. So when I became pregnant a couple of years later with my daughter, who is just turned 18, that's why I said I two adults. So he was 20, he's 21 now, my son, Ben, he's lovely, 21. My daughter just turned 18. Oh, wow. When I became pregnant with her, I thought, well, I'll have a vaginal birth. And so what struck me though about deciding to have a vaginal birth, and I will say that, I'm going to give you the punchline now. She was born vaginally.
Yay.
It was, I dug into the research literature, which I had access to because I'm an academic, so I can get access to all these articles. Is it just didn't seem to me that there were any real potential risks that would keep me from doing that. Right. I knew there was a risk of uterine rupture, but it was fairly low. I knew that the reason I had my first C-section was typically seen as a one-time, thing. The baby decided to flip head up, right? Probably wouldn't happen again. I was young, I was healthy. So I thought I'm a good candidate. And I think that, I was a good candidate. And I think ACOG would agree with that. I was a good candidate for having a VBAC. And so what struck me when I had moved, because I had my son in graduate school, now I'd moved to Connecticut to a faculty job, is that it was really hard to find a clinician who was enthusiastic about, my desire to have a VBAC. And that just struck me as strange, because I thought, I'm looking at the research literature here, which would say there are so many good reasons for me to attempt a VBAC for both my baby, for me, there's not a lot of risks, especially if I'm in a hospital and I'm agree to monitoring so that they can see any blip that might happen that might indicate that there might be a potential tear in my uterus, which, right, the biggest risk is a uterine rupture. And I thought, why are these smart doctors? Like, it's hard work to become a doctor, right? Right? They take a lot of time, a lot of effort. They're very bright. Why are we reading this literature so differently? And it just intrigued me. And so I thought, after I had her, I thought, you know what, I'm going to start to study this because I think it has something to do with the structure of society. Look, I don't think it's that they individually are making this decision to say, women, like me or like many other women, right, shouldn't have a VBAC or vaginal birth after cesarean section. There's some structure that is causing them to make this decision in some way. And so I really just, just absolutely kind of changed my research focus. I still am an organizational sociologist. I still think things are very influenced by organizational structure. But I changed my topic. So a lot of people think you went from studying banks to studying reproduction. And I say, well, yeah, super interesting to me. It's more interesting the banking industry actually to me now. But I didn't change kind of my view, which is that organizations, oftentimes in the imperatives of organizations, are oftentimes driving the behavior of those within organizations leading to these outcomes. So you might learn from me that I have a lot to say about things when you ask me a small question.
Love it. No, our listeners are here to listen to you. So please say anything you need. But it's true, like in your book, the organizations, I mean, doctors and nurses are subject to all kinds of organizations. We have the organization we work for, the hospital. We have, a union, maybe. We have the policies that the hospital gives us, but then there are larger, like ACOG, like you talked about, organizations that affect how physicians practice. And then you have the insurance organizations, which we'll get to. So there's a lot at play in these decisions. So let's dive into your first book, Cut It Out. And this examines the exponential increase in C-section rates across the United States. And as a labor and delivery nurse, I really, really appreciated this book because I see a lot of C-sections and the rate is very high. And you kind of answered my first question, which is why this topic is important to you, because you're personally affected by it. Mm-hmm. But can you talk a little bit more? Something I appreciate about both books is the way that you interview patients, providers, midwives, nurses. Specifically, your second book is more nurse-driven. But can you tell us a little bit about how you conducted your research or how you decided to interview people?
Right. Well, so building off my the first answer to your question, which is, how did I start studying reproduction? It was based on, my experience. And what I thought is, I did have that vaginal birth, but it was something I felt like I had to really advocate for myself to do in several different places. And then I thought about the resources I had as a faculty member, as a college professor, as someone who has a Ph.D. That entails some respect that doctors might give to me and might not give to everyone. Sure. Right. And I started thinking, like, if I have this much trouble, like, advocating for myself, having them question my motives, right? I one time had a doctor say to me, all I really want is a healthy baby. As though I didn't.
You don't exist.
I want a healthy baby too. But, so I thought, if I'm being questioned like that, and I have a lot of privileges in my society, right? Yeah. Starting with my race, going on to my class, my profession. And I thought, this has to affect so many people.
Well, right? You have access to journal. Like, had you not had access to that, I also have that because of the institution I work for. So I'm like, oh, let's go to the literature. But like, someone isn't going to have that,
Yeah. And so, built up that. But then I thought, if I want to understand this, if I want to understand why so many women are having C-sections, right? I think I need to talk to the people who are doing the C-sections. It just like it was this light bulb moment for me. I need to talk to doctors, but I need to talk to midwives and nurses too, right? They're not doing the C-sections, but they're all around, right? This decision.
They're part of it.
Right. And so that's when it became really important to me to do interviews of people who were involved in these decisions. So I started with physicians. I included nurses, I included midwives. I started to include doulas, but it was kind of hard for me to access that network. And so I only did a few doula interviews, although I think that can be important. I think that they are important as well in terms of their perspective. And so, I did what's called snowball sampling. I started with, actually it was a doula whose husband was an OB. And what she said to me is, I'll tell him he has to talk to you. So he was like my start, and he appreciated what I thought was one of the things that was so interesting to me is that the clinicians I interviewed, so midwives, nurses, physicians, overall were very appreciative that I was asking these questions. And so I think he appreciated that I was just asking him, about like, well, why does this happen? And can you talk to me about your perspective? And I had a whole interview schedule about, different situations and how they would make decisions and how they came to decisions and how things had changed. And what he said after that is, he kind of said something, I think this research is good. And so I'm going to invite you to one of my practice meetings. And so can you come in 2 weeks at 8 a.m., it was like an hour and a half drive. And I was like, yeah, I can. So, so he was kind of the start. And then a snowball sample is kind of like a snowball that your respondents build up from other respondents. So they kind of, like you would pick up snow when you were building a snowball, right? You do the same thing with respondents.
Oh, okay.
And so that's how I was able to access respondents. Eventually, ACOG, I was in Connecticut. They allowed me to come to one of their meetings in Connecticut, a state meeting, and kind of distribute information about my study. So I was kind of able to several places try to get physicians from around the state, mostly in Connecticut because that's where I was based. And then nurses, it was the same kind of way of find a nurse and then have the nurses use their network. And the midwives the same way. So I thought it was really important to talk to them, all because I thought that they made the decisions. I included women in the patients. Actually, I'm just gonna be honest with you about this, how the women came in, the patients came into the book. I was very much interviewing the clinicians because I think all the evidence suggests that most women don't seek C-sections, primary C-sections, electively, right? Listening to mothers' data where there's 3 waves of representative samples of women giving birth. There have been 3 waves done in about the last 12 years. And what you find when women are asked about a reason for a primary C-section, hardly any of them say that they sought it outside of a physician's recommendation. So it seemed to me that I wasn't going to ask women why they had C-sections because it's the doctor.
Right.
We decided this. I will say that my fabulous editor at NYU Press, where I've published both my books, Eileen Kalish, is just a wonderful editor. What she said to me is, okay, right, you're a feminist. Why don't you go get some women's voices in your book? And that really struck me. And I said, wow, you're right, Eileen. I should get some women's voices. But it wasn't that I didn't think they were important and I didn't want to talk to women, but the structure I saw in society and the way that medicine was happening around reproduction and choice of mode of delivery, as I didn't feel like women had a choice.
Right. They were being told what to do. So
that's kind of what I felt like, or they were persuaded, right? They were persuaded. So anyway, so we decided to talk to women. So actually I had undergraduate research assistants. I trained them and they went to a hospital in the Hartford metropolitan area. We worked with the hospital and they approached nurses of all who had women in the postpartum unit of this hospital who were at day 1. 0 was when they gave birth, 1 was the day after, and tried to interview as many of them as they could. And we didn't find the women, it's kind of what I thought. Most of the women who had C-sections, it was for a reason. And I should say when I talk about C-sections, that C-sections save lives. I totally understand that. And I absolutely, kind of always mention that in any talk I give. C-sections save lives. And so, babies become obstructed, moms have cardiac issues and they can't safely give birth. And, kind of there are many reasons babies have trouble when they're, if their heart rate drops, right, precipitously, they need to come out quickly. And I think the problem we have in the United States is that the rate is, sitting at 32%. And that is much higher than the World Health Organization or Healthy People 2020 would say is a healthy C-section rate for our country and for our country. So it's more that that rate is so high. But the women I spoke to, it was mostly if they'd had a C-section, it was a documented medical reason or suggestion by a physician. It wasn't that they themselves had asked for a C-section.
Right, like the too posh to push, right? That kind
Too
of
posh to push. That's largely a myth of the too posh. It's not that there aren't some women who, for various reasons, not just being too posh to push, but they may have other reasons that they choose to have a cesarean section. But it's just a very small percentage of women.
Yeah.
It's kind of very, very small percentage of women. And I think that there can be there can be this like belief that it's like lots and lots of women.
Right. Because it's still major surgery, and a lot of us aren't really willing to sign up for major surgery.
No, especially not when you're going to have a baby to take care of afterwards, right? It's absolutely. So I think most women don't sign up for that.
I really valued that this book unveiled or attempted to educate the reader about the complexities that can drive medical policy. So I kind of want to dive into that for a second, such as the legal and the power structures that are at play, some of these organizations, right? So can you talk about that a little bit more and what you saw in your research as far as the legal and power structures that kind of drive these decisions?
Yeah, so what became interesting to me was the way that the hospital protocols were made. And this is something maybe you and I can like chat about and brainstorm about. I've only really studied a couple of hospitals, but what's interesting is the protocols about, how often you monitor a mom in labor in terms of, intermittent fetal heart monitoring versus continuous heart monitoring, how often you check her blood, for diabetes, how quickly you increase Pitocin, right? Things like these are all protocols. And there's typically, right, there's going to be a protocol book in the hospital, right? And it's going to be online too, but there usually is a physical book. Is that still right? Like there's
not so much. We've definitely moved away. At my current employment, we do have a book, but it's mostly like a dumbed down version of it's like what you need to know really quickly. But
okay, right. Yeah. But there will be very defined protocols about every decision that is made in labor and delivery. Mm-hmm. And it would seem that those protocols should be based strictly on evidence, evidence-based medicine. But what I found by talking, and this was really by talking to nurses and doctors at different hospitals, was to hear, well, we have a committee that makes these protocols, and it's based on, ACOG, the American College of Obstetricians and Gynecologists, and A1, if I have to say this quickly, I'll mess it up, but Association for Women Obstetrics, Women's Health, and Neonatal. Did I get that right?
I think so. I always just say A1 because it's too much.
I try to define it right. And also, A1, they look at A1's, kind of policies and, kind of these different practice guidelines they would put out to base their policies. But then what became really interesting to me was to hear how the protocols then that were established based on, committee discussion, based on A1, based on ACOG, would change after a bad outcome.
Yes.
So, right. And so a couple of, examples of this, I talked to a nurse at a hospital that allowed telemetry. So that would be that, you have a mobile fetal heart monitoring unit. You can probably tell this all better than I can, right? Right, that it uses like radio signals, right? So you can walk around instead of being, what some women often refer to as being tethered to the bed, right, for their contractions and for the baby's for the fetus's heart rate to be monitored. So they, had telemetry policies. Who was eligible to have telemetry, how long they could use it, things like that. And then they had a woman who was on telemetry. Baby looked fine, right? They said the nurse told me we would have thought the baby looked just the same had the mom been on a more traditional unit hooked to the bed. And it ended up, they had a fetal death, right? A tragic, tragic situation, a fetal death. And what happened after that is no one could use telemetry. Wow. So, and what the nurse said is this wasn't telemetry. This was sometimes bad outcomes happen, and and you cannot predict them. You cannot know and she said, and this wasn't telemetry because, when we looked at this strip, we wouldn't have done anything different had she been in bed. But because the mom was on telemetry, what the nurse said is you will no longer find anyone on telemetry in our unit. So that suddenly it's a bad outcome that changes protocol that's not linked to any kind of evidence-based medicine. And I heard, other stories about, ECVs being, once there's something that happens to a baby, a bad outcome after an ECV. Oh, now a hospital doesn't do ECVs. So I would talk to nurses from different hospitals and hear these different stories. And it was interesting to me was how it wasn't the same outcome. It was like a moving target. It depended on what happened at your hospital. And it became, listening to the nurses, it was a way for the hospital to show they were doing something, right? This is never going to happen to us again. Well, if you use that to make your protocols, if you allow risk managers to make your protocols, and that is a risk management decision, right? If you allow risk managers to make your protocols, right, women will have no choice at all. Right. Because to a risk manager, the safest thing is to totally control, right, labor, which is uncontrollable. Right. And so you won't have telemetry. You won't have women moving around. At the slightest blip of the, EFM, you're going to have a C-section. So if you allow the power of the legal professionals in your hospital to have that much influence on your protocols, it's going to influence outcomes. Yeah. So that's one of the ways I saw. Another way that really surprised me and made me go and dig in some research is when I was talking to a doctor and he said, I was talking to him about vaginal birth after cesarean. And I was like, well, what is it that leads to this low rate of VBAC? Can you talk to me about that? And he was talking about it. And then he said, well, it's not just my malpractice insurer who doesn't like me to do VBACs. He said, no, it's not them. It's the reinsurers. It's the insurers that insures the malpractice insurers who say, we won't cover a VBAC if you have a bad outcome. So he says, it's not even my malpractice insurer. It's the reinsurer.
Yeah.
Anyway,
that was a new concept to me reading your book. Actually, as a nurse, I don't carry personal liability. I know some nurses do. I don't. It goes back to the policies thing. If I'm following my policies, then
you're following your policy.
That's my back, right? But I know that for some nurses they do carry their own, but I don't. So that was like a new concept to me. Can you explain that a little bit more for our listeners?
Yeah, well, I'll explain it as best I can. So
yeah, it's kind of a confusing thing.
Happens when insurance companies insure themselves against loss. So malpractice insurers hold insurance too in case they have a big loss due to a malpractice case that's in the millions and millions of dollars. They'll have insurance that if that happens, right, they're insured against those big losses. And that will, reimburse them. Just like if there's a hailstorm at my, I insure my house, right? Homeowners insurance, right? There's a hailstorm I didn't predict. I wouldn't understand, I don't have the money to pay for my new roof. I pay insurance premiums. And so the insurance company is going to say, oh, this out of the ordinary event, I'm going to pay that because you paid in premiums. So it's similar, right? The malpractice insurers would insure themselves against some kind of a big payout they have on a malpractice claim. Okay. And so anyway, what an interesting story about this is I was a professor at Trinity College in Hartford, Connecticut. And one of my students, when I was writing the book and just had learned about reinsurance and was wrapping my head around, it's not the doctor saying no VBAC. It's not the malpractice insurers. It's the level above them. And I was thinking how far removed that is from women. One of my students I think she was graduating. They have a senior dinner and she was telling me her parents, were going to come to the dinner and she mentioned to me that her dad was a reinsurer. Oh. Are you kidding? Can I talk to him? And anyway, so I did talk to him and he confirmed a lot of what I was, is this the case? Would this happen? He's like, yeah, that is exactly the type of thing that happens. And anyway, what the student said to me is, he was so delighted with your questions because it's like one of the most positive responses I've ever had to introducing my dad as a reinsurance agent.
Yeah, it's not probably very popular.
It's like usually people don't know what he does. And if they do, they're not interested in. I was like, can I talk to him? So there's that. And then, like what you mentioned, right? Nurses are, kind of, one could, sometimes you'll hear stories about like, I had a nurse and she wouldn't let me, right? She wouldn't let me do something I wanted to do. She wouldn't let me turn up the Pitocin quicker so I could get the baby out quicker. I've heard that before. Or she wouldn't let me go to the bathroom on my own if I'm, getting I'm losing my words now. When you have high blood pressure,
Magnesium.
Thank you. That makes you a little woozy, right? Makes you woozy. So you get help to the bathroom, right? And so somebody might say, she wouldn't let me go on my own, and I wasn't woozy at all, and I wanted to go on my own. And why did that nurse do that? That's so awful. Well, why? It's pretty clear why the nurse is doing it, right? Is because the nurse has to follow the protocols that the hospital establishes as a standard of care. And if she doesn't, and there's a suit, and the nurse is named in the lawsuit, the malpractice suit, that hospital's malpractice insurance will not cover her.
Right.
And you're probably told that, right?
And now more than ever too, nurses are starting to take classes on how to protect themselves legally, because this is becoming more and more of an issue. And so we're taking classes on how to chart better, so that, there are no gaps in how to follow policies better, because this is a new thing, is the insurance
for nurses.
Yeah,
absolutely. When I was writing this book in Connecticut, and it came out in 2013, so I was studying in the early 2010s, I was studying this. And while I was doing that, maybe right before I started my study, the first malpractice suit in Connecticut had just been settled, and it named nurses. And that was the first time that had happened. Mm-hmm. And so that makes sense to me, right? That this is
right. And not that we shouldn't be held accountable. That's not at all what I'm saying.
No. But it's a different accountability. It's a different kind of accountability.
But it's hard because, and that's what I try as a nurse to explain to patients. And I think this is part of the problem. We need to explain to patients why we're doing things. And we need to say, and I always in any conversation I have is, this is your body. This is your baby. This is for you. Like, at the end of the day, you make the decision, but this is why I don't want you to go to the bathroom by yourself. This is why. And then it's like, oh, well, of course I don't want to fall. And, it's like, can we come to a compromise? Can we work together? Because I want what's best for you. And this is what studies are showing is best for you, or, sometimes not studies showing, but, so I think that gets to your book too, is like, we need to be able to present this data to everyone, not just those who are white and affluent and have access.
Absolutely.
To journals. We need to present this to everybody, and it needs to be evidence-based.
Absolutely. And I appreciate, how you approach this. And I do think there's, kind of just as a little insight into why did I write the second book on nurses? It was because the first book let me know like how much nurses do. So I thought, oh my gosh, like if I'm going to write another book, it's going to be on nurses.
This is it
because it suddenly became so clear to me, talking to nurses, that nurses were so integral to the care of these patients that I needed to understand nurses. But so I appreciate, I'm so appreciative of the hard work nurses do. And when I wrote that book, I did ethnographic studies. So what I did is I followed nurses around, and I would have people say to me, oh, Theresa, you're doing this because you want to be a nurse. I would be like, are you kidding me? Do you know how hard they work? I think I have a new appreciation of how hard nurses work, and I don't actually think that's for me. Like this is physically, because it's both. I'm not telling you anything you don't know. This is an outsider view, but the physical and the emotional work that nurses do is just incredible. So I appreciate hearing you and the dedication you have on. I want to explain. I want women. I want my patients to know, that they're in control, and I try to give them this evidence. And I think to me, what that puts nurses in this bind, doctors and nurses are in this bind, because so much of what you are required to do is about the legalities, right? It's about not getting sued. And if you get sued for malpractice, that you can show that you did everything right. And then I think, imagine, right, if we lived in a society, which, there are people who talk about this all the time, where malpractice reform was done, where all babies who something was wrong at birth, who needed care, were given it, right?
Yeah.
Like that we had a malpractice that was outcomes based, it was need based. So it wasn't about malpractice. It's just if a baby is born and has a need, right, that requires further medical care, more intensive medical care, well, there's, we fund that as a society. If a mom is injured in birth, we fund that. And if there's malpractice, that's separate.
Right.
Right. There's a separate system for that, because when it's not that way, right? When they're integrated together, it means that so much of medical care is about preventing, not preventing malpractice, preventing being sued,
Right.
and being and having to pay out a malpractice claim. It's my understanding, talking to doctors and nurses, right? There are a few bad apple doctors and nurses who do things wrong, and they should be held accountable on malpractice claims, right? But most doctors and nurses are there because they want to help patients, right? They're not trying to do things wrong. They're trying to do things right. But then the question is, are the legal-based protocols actually, and insurance, I would say also insurance-based protocols, actually preventing them from providing the best care they could? And I think a lot of times it is.
Yeah. You hit on a lot there. And I think you offer that as kind of a solution to your book, as far as like, because a lot of people, when there's an infant with a bad outcome, they're suing because they can't afford
it.
Care. And it's a big burden. And it may have just been an outcome that was going to happen regardless of how they were cared for, because as you said, birth is risky. The only way to avoid it is to not have children. But there are sometimes just bad outcomes that we can't prevent. And that's one of my favorite things too about your book, is at the end, your last chapter offers and focuses on solutions to improve maternal. And I love that, because all the time we're always like, okay, you come up with a problem, but what's the solution? And you very, very explicitly list the problems, and then very eloquently come up with these solutions. And I love that. So since this book is a little bit old now, a little bit, but it's still so
2013, right? I'm like, yeah.
But the rates haven't dropped. Like they're still, yeah. So have you seen any of your solutions implemented in society since writing your book? Because the C-section rate seems unmoved. So do you have hope? Like where?
I know, right? Well, I was thinking that in preparing for talking to you today, I was, looking up the 2020 C-section rate, and what we see is that, it hovered at 33% until 2013, and it dropped to about 32% in 2014, and that's still what we're at.
Yeah.
So it's largely unmoved, and I will say that there are, so I was hoping by now that we would see significant decline, but I think that we do see, I would say that some things have changed, and that I think that for some women this has had an effect, but so many things in our healthcare are driven by cost. Mm-hmm. And a lot of the things that I suggest for individual women, so I frame the solutions by what should doctors and nurses do, what should women do, right? For women is often things that are not free, right? And so the things that are not free, I would say we have seen an increase. We've seen an increase in out-of-hospital births, whether it's home births or birth center births. So we have seen those numbers. I mean, this is tiny, change.
And they're having their own issue, right? Like, so birth centers have a hard time getting insurance. So that's why we don't see those numbers really climbing, because we don't, it's really hard to insure a birth center and for them to make money because they're paying.
Absolutely. Well, and we have we're really fortunate. I live in a small metropolitan area of about 250,000 people in College Station and Bryan, Texas. We're kind of twin cities, so smallish. But we have a birth center in town, Jubilee Birth Center, wonderful birth center. I take my students on a field trip to the birth center, and Toni Kimple she's a certified professional midwife. She runs that birth center. She trains midwives. I will say that part of the reason we do have that birth center is Texas has apparently very, very good laws for professional midwives. So midwives who are not certified nurse midwives. And so we have some of the best regulations for that, and we allow licensure. We can get insurance to reimburse, but it's tricky. And in fact, that's some of the, I think, problem with birth centers is that it's very difficult often for them to get hospital reimbursement. Although one of the things that was put into the Affordable Care Act was that Medicaid required facility fees to be reimbursed to birth centers for Medicaid patients. Mm-hmm. That was a little, that was intentional by some really influential advocates led by Susan Jenkins of the big push. But even with that, when I've talked to Toni at our birth center, she said that the burden for her to file insurance claims is more than she can handle.
Yeah.
Right. She's a small business, she does birth. So she said that some of her patients have been successful at, filing their own insurance, and can get reimbursed, but not all of them. And even though it's a few $1,000s, which if you think about how much hospital birth is, it's much less expensive. But the thing is, if you have insurance, you're not paying that out of pocket to the hospital. So it's a significant difference for the consumer. And home births are the same way, right?
My husband and I were expecting our first, and
congratulations.
Thank you. Being a labor and delivery nurse, I was like, I'm not delivering in hospital. We have one birth center in our area, which we have a very big city that I live in, and my insurance will not pay for it. So fortunately, but luckily, that's important to me. We've saved up our money. We're going to pay out of pocket for it. But it's like my husband at first, before he's like, wait a second, we can deliver for free at a hospital where you'll have top of the line care, and, or we can pay $8,000 out of pocket.
And, wow, that's expensive. $8,000. Wow.
And you will get less care, so to speak, less interventions, less, I don't understand, but it's so funny. He's been so great. Like, he's so supportive now, and he's turned into this, like, he's like a doula almost, but I kid. But yeah, and he's understanding now that we're having our own baby, why this is so important to me. And so anyway, but yeah, it's just crazy, right? Like, consumers just don't have, and it's crazy because I'm a healthy, it's like, I don't need to be in a hospital.
You don't need to be in the hospital, right?
So,
right. And that we don't, so it's, when that's one of the things that always bothers me about the concept of, where do you choose to give birth? And I think most women don't have a choice about where they give birth, because, even in terms of a hospital, your insurance may only cover one or another hospital. So if you decide to do a hospital birth, you may not be able to choose your hospital. If you choose home birth or birth center birth, it really depends on the insurance you have as to whether they'll, reimburse. And it can even change. My sister-in-law lives in San Antonio. They have a few birth centers in San Antonio. She gave birth to her first daughter 9 years ago at a birth center, and she was able to get reimbursed by her private health insurance company. She had to call, she had to argue, she had to supply, comparative data on the cost, but she got it. 2 years later, she had a baby and they didn't want to reimburse her. Same birth center, same insurance. So it can tell you that, kind of the very uncertainty, and not everyone has those resources, right. but we do see an increase in out of hospital births. I will say that there seems to be a burgeoning of independent childbirth classes. So that's another recommendation I have for women, not the hospital-based classes, because research shows that the hospital-based classes really, for the most part, not all of them, but most of them, the research shows, really socialize women into how to give birth in a hospital. Yeah. So, the topics are, when will you need a C-section? When might you need a C-section? When should you be augmented? When, what can you expect when you check into the hospital? And I don't mean to dismiss hospital-based childbirth classes, childbirth education classes, because I think many of them do still provide, education about the physiology of childbirth and such, but they also have a healthy dose usually of hospital policies and protocols. Right. If you go to an independent class, they won't have that. There are different ones, Lamaze, Bradley, Birth Boot Camp. There's several different ones. Lamaze and Bradley are the most well-known, but I think Birth Boot Camp is one I see in Texas a lot. And they focus when they tend to be more in-depth, they tend to be longer, they tend to be smaller classes, and they tend to be almost solely about physiology of labor and birth, and then how to support women in labor and birth. And so, if you can find one of those and you can afford to take it, oftentimes I find childbirth educators who teach these independent courses are very committed to their students. And I've seen several of them that have sliding scales. Yeah. And so there's a commitment to this. Right. And so they'll, say, if you can't afford this, you should email me, you should let me know, and we can work something out. Another thing, is to have a doula, a labor assistant. Doulas, of course, are labor assistants who are not they're not medical assistants. They don't do anything medical, but they just support moms. And all, research is so conclusive on this. women who have doulas have shorter labors, more likely to have vaginal births, more likely to be satisfied with their outcomes. And so I think that can be really helpful. And again, that is an expense, although some hospitals do have doula programs, which are free to moms. And if you can't afford a doula, if you contact some of the doula agencies in your community, there are sometimes student doulas who need to attend a certain number of births to be certified. And oftentimes they'll connect individuals who don't have the resources to pay for a doula, a private doula, but might be able to connect with a student doula who they feel comfortable with.
Yeah.
So those things, are all things that women can do, but they all cost something. And I think that more women are using doulas out of hospital births, I think independent childbirth classes, but it's not having much of a tick on the C-section rate. Because I think it's still such a small percentage of women, and the women who are doing these things may have been the women who were most successful at having a vaginal birth in the hospital, because they're the ones going in with a notion about what they really want to happen, and maybe they're steering away from some of the interventions that we know are linked to higher C-section rate.
Right. Right. And just to that nod, if any of our listeners are in the San Francisco Bay Area, there is one organization, two of doulas, that provide care to women of color to help against, the maternal morbidity and mortality that's happening for Black women. And that's Sister Web, and they're a great organization. So if you're able to afford it, or maybe a person of color, then this is definitely an organization that will help you get a doula and support you in that. So just another plug for other women to get the care and support that they need during their.
Absolutely. Well, and when you talk about, maternal mortality crisis in our country it's so extreme. And so, any way to look at this, and to help women of color in hospitals, we need more nurses of color, right? Right? Because if you look at the data on nurses, I think it's even, there's less diversity in nurses even than doctors.
Really?
Nurses is a very, very much a majority white occupation. More doctors of color, doulas of color, right? And we need that to support women of color in hospitals. And what something else you said to me is, you said, we need to ask questions and talk to all women in the hospital about evidence and about choice, not just white upper middle class women. That's part of it too, right? There's some real important research that shows that women of color, specifically in labor and birth, are not treated that way, are treated as lesser than, are talked down to, or not given, the same types of privilege and not the same respect. And we get, kind of when we see this, Venus Williams, even her near maternal mortality crisis with, kind of pulmonary embolism, and she's saying in the hospital, I've had this before. This is what's happening to me. And they're dismissing her.
Right.
They're just dismissing her. Like, not to say that only what happened to her is because she's African-American, but it's certainly like a very telling example of what can happen to women when you don't listen to them.
Right. Yeah.
Right. A top athlete who knows her body, right, like better than most women.
Right. And you would think,
Yeah, absolutely. So I think they know that. So in all of that, like, is all involved in maternal mortality crisis. It's kind of builds on, legacies in our country of inequality, and unequal power. And then that, carries over to all aspects of life. And I really, encourage all of your listeners to check out Reproductive Justice Framework and Sister Song in Atlanta. This is a way of thinking about reproductive, going beyond reproductive rights to say all aspects of women's reproduction, whether to have kids, when to have kids, raising healthy kids, is all linked. And this was kind of really a way of African-American women to respond to what they felt was a very narrow view of white feminists on reproductive rights. And so when you see that, then you start seeing maternal mortality as linked to, right, all of these structures that lead, that kind of give resources to us to have healthy lives or not.
Yeah.
Right. Anyway, so that
No, I love it. I love those plugs, and we can include little links to that too on our.
Right. And there's a really great primer on reproductive justice that I can send a link to you for a
That'd be
book that's
excellent.
really accessible. I have my students read in class.
Awesome. So I want to connect all of this to the work that we do in bioethics and culture a little bit. Jennifer Law, the founder and president, and I did our own research on surrogate mothers, and we're still kind of waiting on that to get published. But and we found that women had 4 times higher odds of delivering via C-section during a surrogate pregnancy than with their own biological child or their own biological pregnancy.
Wow.
And some of that was due to the high-risk nature of surrogacy pregnancies and the complications that ensue because of that. And some of it was honestly to merely convenience. There was a couple maybe coming from China. They wanted to be there for the birth, so they scheduled a C-section so that everyone could be present when the baby was born. So my question is, do you think that assisted reproduction, specifically surrogacy, is adding or affecting the C-section rate in America?
Oh, I think so. And I will say this is anecdotal. So I haven't studied the effect of, of assisted reproductive technologies on C-section rates, but the anecdotal stories I have are, some women I've spoken to who have had years of infertility and then are successful in a pregnancy using some kind of assisted reproductive technology, are sometimes unwilling to risk anything, right? And so I've heard women say this, I'm unwilling to risk a vaginal birth. I just think I don't want to take any risk at all. And so it's part of our notion in the US that C-sections are just safer, right? And I think that notion gets really embedded in a lot of people's minds about risk. And so I have heard that, like, I'm unwilling to risk, or if I have a vaginal birth, I'm unwilling to risk anything if anything looks wrong, right? Mm-hmm. So if a doctor says, oh, the fetal heart rate has dropped a little bit, I'm okay watching for a while, but we need to keep an eye on it. Right. If this is, and it makes sense. I always try to say, put yourself in the shoes. So, right. It kind of makes sense. If you have, if this pregnancy has taken years and years and years, you don't want to risk anything. And if it's put to you as though vaginal birth is risky or continuing to have labor is risky, you might more quickly jump to a C-section. But I do think, I do think that these types of relationships, and I haven't looked at if there's research on that. I tend to think it probably does affect the C-section rate. But again, what I have is more anecdotal, like talking to women. And I think a few nurses and midwives said some things to me about this too, about, particularly the issue with IVF. And if a baby is conceived IVF, that, moms might be unwilling to, to really, they don't want to risk anything for the baby, and they feel that maybe a vaginal birth may be, quote, too risky for that. I don't know. Is that that with surrogacy too? Is it about risk? Is it about we don't want to risk it, or is it more about timing?
It was but a lot of and we broke it down. I don't have the data in front of me, but broke it down based on like emergent versus urgent versus breach.
Yeah.
And more often they were more urgent cases. That were happening because surrogacy is a higher risk.
Yeah, that's so interesting.
So
yeah, that's interesting.
So not that C-section would be needed, but that we did have some mothers tell us that it was a planned C-section just out of convenience for, which is really sad because C-sections are not without risk. And I think that I want our listeners to really know that is that this is major surgery, and infants can have poor outcomes because of being born into this world surgically, rather than, and again, to your point, not that C-sections don't save lives, they absolutely do. And they're definitely warranted. Very grateful that we have C-sections.
Yeah, absolutely. Absolutely.
But they're not safer. And that's a little bit misleading, I think.
No, absolutely. They're not safer for moms or babies. Right. And the other thing that I sometimes will talk about is they're not painless either. Yeah. Because I've heard before, well, if you have I've had, I've heard this just, anecdotally, like, oh, I'd rather have a C-section than vaginal birth because I don't want to go through the pain of birth. And my answer is, well, you may not go through the pain of birth, but you're going to, after that surgery, you can't, you're not going to be pain-free forever, right? Once that pain, the anesthesia wears off, right, you will have had major abdominal surgery and you're going to have some post-surgical pain for sure. So it's also not pain-free. And I sometimes hear that, I don't want to go through the pain of labor. So I think I'll have a C-section. And I think, well, you're just delaying your pain.
Yeah. Your pain will come after.
It will be a different pain. It won't be uterine contractions, but it will be pain from having had incisions, in a major organ.
Yeah. So again, in both books, you have a lot of stories, and I think it's really fun that you got to interview these people and follow them around. And kind of, were there any interviews or stories or experiences that really you just kind of, they had a lasting impression on you, or maybe you were even caught off guard? You're like, whoa, this was not what I was expected. And can you share?
Yeah, I can tell one that's like, let me start with one that was like an eye-opening, oh my goodness, the state of obstetric care in this country is concerning. And then I'm going to end with a happy story.
Perfect.
So I think I have this in my book, but I was interviewing an obstetrician for the first book, and he was the sweetest doctor. He got me coffee, took me to his conference room. The nurses all liked him, right? He was a nice guy. I mean, and he was like, it's just super friendly, telling me stories. And then he got serious. He showed me web pages from prosecuting attorneys' websites who prosecute malpractice. And then he said, I have a friend, he, had a bad baby outcome. Now his kids at school, the kids are taunting him as a baby killer, like your dad's a baby killer. Right. And then he said to me, so you will understand when I tell you that I sometimes call my wife to see if she thinks I should do a C-section when a strip is bad. And he said, she's not a doctor.
Right.
Wow. Right. So it gets you it puts you in his world, right? In his world. Right. So that tells you the state of care, right? And I don't think that I don't think any of us in birth would hope that our doctor is calling his spouse to decide on our care, right? So that was trouble. So the happy story was in my second book, where I was following nurses around, and there was a patient who was very hesitant about particularly vaginal exams, so internal exams to check the dilation of her cervix. She got really upset, really nervous.
Okay.
And she had the best nurse for this, who would sing songs, made up songs to make her happy. While before doing the exam, she would do these silly songs and do a song and dance to try to lighten the mood, and provide her care. She would put up a screen so that if anyone opened the door, first of all, no one should open the door, but that she was worried someone would open the door without knocking. So she put up a screen, even though we knew this wouldn't happen, right? She put up a screen to make sure she was okay, right? I was behind the screen, right, at her request. But she had this best nurse, and I talked to the nurse about it, and she said, well, I always make up songs because it just makes it easier for her. Yeah. And it was something about her. She was so dedicated to the patient and meeting the patient where she was at. And the woman and her partner were terrified when they heard the nurse was leaving, right? Her shift had ended, it was ending. And so they even asked her about it. And so she stayed uncompensated, because she just couldn't bear to leave this patient who, was not dilating quickly, that they were, so she was being checked sometimes just because of that. And she needed a nurse who understood her. And I just think that so many nurses are like this. They can, and this is why I think it's hard to be a nurse, right? Because you're trying to follow protocols, you're trying to provide the best care, but nurses, this is what nurses do, is they meet the patients where they're at. And, I had the privilege of watching this and seeing this happen. And there are more stories I could tell you about these amazing nurses I watched, but I just, they were just such a neat couple, who could feel comfortable even telling her what they needed. And then I don't think they said sing to us, but but they just needed a safe place. And, the nurse, how did she come up with singing? She's like, oh, I do this sometimes for patients who need it. Anyway, so that's my happy story.
That's great. No, that's great.
Are you thinking if you're going to sing to a patient?
I have a terrible voice. I think I would cause more anxiety than not, but I just, and you're right. It is hard because I have stories like that where I've stayed with patients, but then, it's a hard balance, right? Because we go home and we're also nurturing sometimes to our families and whatnot. But so I want to switch gears a little bit and from your book and talk to you a little bit about your classes that you teach on gender. Okay. And as you probably know, I think you know that we just produced a documentary about medically transitioning children from I'm trying to decide where to go with this, but do you talk about this topic in your classes? And if you do, are you seeing a shift in the way that you educate your students about gender and sexuality?
Oh, for sure. Yeah. So I teach an intro to gender course. So this would be a course that there are a lot of freshmen, sophomores in. It meets some of the core curriculum requirements that all students at Texas A&M are required to take. And so, so it's a high enrollment class. And so that's an intro to gender course. And so we do talk about issues of gender, sexual orientation. And I would say the issue particularly of transgender issues, we have started covering, I think, more intensely in the last 10 years for sure. And one of the examples I give to my students is the term cisgender, right? Cisgender would be that your gender identity and your biological identity as based on your reproductive organs, right? Either being male or female, and your gender identity align, right? You're cisgender. That was not a term 10 years ago,
right?
Right, being cisgender, it was assumed, right? Everyone was cisgender. So if you weren't, then you identified yourself as something else, right? Either transgender, or of course there are other gender identities that one could take. And so I tell my students, right, you know what cisgender means, right? And they say, yeah. And we talk about, well, why is it that that's a term now? Well, it's a way to say that cisgender is just one of many gender identities, right? So it's not the gender identity, and everything else is different than, right? And so putting a term to it is a way of thinking about saying that this is one of many gender identities, and gender identity, not everyone has the same gender identity. So I think that just is, a demonstration of how quickly things have changed. I also think the use of pronouns, you might see in my Zoom, right? I have she, her, hers. And this idea of pronouns in your, I have in my email signature, and the idea of suggesting your pronouns or putting them on signatures or on your Zoom screen is that some people won't have gender identities that align with the gender people think they are, right? And so if you are someone who goes by a different gender identity than what people would assume, so if I had had he and his, or if I had said they and theirs, right? You wouldn't know that unless I put it, right? You would assume I'm a she, her, hers based on, my hair and my color of my shirt and such. But it puts then, if I don't say she, her, hers, when it seems as though, well, most people would guess this of me, right? You're putting the burden on everyone who doesn't identify as cisgender. And so the idea of we should all do this is it's a way of recognizing that this is something we should all say about ourselves, not just people who identify as non-cisgender. So, so I think that we have had to shift the way things are discussed about gender as societal norms change. So it's kind of an interesting topic to study because of that. And so I have had students, I had a student come to me in my class, I haven't taught gender in just a few years because I've been teaching some graduate classes, and I've had some teaching release for administration. So it's been a few years since I taught gender, but she just, he came to me and he was gender transitioning, considered himself as binary, but transitioning to a trans man. And he came to talk to me and said that he had never before identified himself to someone as a trans man, but he thought that people knew that he was identified as gender binary, but that he was transitioning to, kind of having an identity as a man. And that he just appreciated that we talked in the class about these issues because it made it easier for him. Mm-hmm. And, hearing that makes me feel like this is, this class is good for students to take and talk in a non-ideological, non-polemic way, to just talk in an academic way about these different societal issues, sure. And so, so we do talk about this. I'm gonna look at your film because that might be really fun to have in my class, and maybe have you and Jennifer come and give a guest lecture.
Love it. Love it. We actually
we do talk about it. Yeah. And I think you have to meet the students where they are, and the students, this is interesting to them, like this kind of topic is very interesting to them, but they don't always, and this isn't just students, this is when you have quick societal change, it's everyone, right? Everyone has trouble talking about it. Right. So you might not have the words to talk about it. You might not even understand exactly, how things are changing. And I think it's so nice for these students to be able to read a book, to come to class and have discussions and kind of help themselves make sense of it, right? Not just the student who is transitioning, but the students who are not transitioning, and the students who are cis and the students who are non-cis, that they have a place that they can kind of think about this and talk about it in a way that people aren't judging them. Yeah. And I always, I'm very clear in my syllabus and the first day class, we always talk about a safe classroom, a non-judgmental classroom, respect we have for others. And I will say that I very rarely have any trouble with students being disrespectful to each other. It just, you set those ground rules at the beginning and they respect them. And I have a lot of respect for undergraduate students. I think sometimes, every young generation, right, as a society, we focus on what's wrong with them. I mean, I'm older than you, so I don't know if we're exactly the same generation, but our generation or generations had that too, right?
Oh, sure.
And so, there's always there's always something wrong with the upcoming generation. But what I see and what I love about teaching undergraduates is I see this generation of super committed, smart, right, advocates often, these students who, are, to me, they're like go-getters. Like, I think this generation is great. I think this generation has grown up during an economic crisis, when there's been a lot of social upheaval. And I think they've had to think about a lot, and they face it head on. And I just have a lot of respect for undergraduates, these 18 to 20, 25, if you go up to the upper end year olds, because to me, they're facing a lot of societal change. And we expect a lot of them, and they generally, kind of meet those hurdles. Yeah. So I love teaching undergraduates for that reason. I just, to me, it's like a fantastic age to teach. I don't know how I would do it in middle school.
Full circle to what you said before, right? Like from being wanting to go into law to being a teacher, like affecting change. You're giving a safe space for people to facilitate discussion and to talk and to learn. And this is a group of people, hopefully, if you're in school, you're wanting to learn, you're wanting to better the world or change at least your.
I think they are. Yeah, absolutely. And it's so, like, my favorite emails are I'll get emails that say, Dr. Morris, you might not remember me, but I took this class, and usually I do remember them. They think that they're forgettable, but it's so nice to get those emails and to hear where they are. And, and I've been teaching 20 years. So I've been doing this long enough that, like, my students have babies and right, are like successful in their careers, and right. And so I'll hear from them about different places they are. And it's just so neat to see them be successful. And, kind of, I always love the part, although I shouldn't love this so much, but when they say, like, this class, was so instrumental, or what you taught me, right? those are always nice. But even without that, right, it's just nice to hear from them. And I do hear, we get these emails, and I think all of my colleagues love them.
Yeah.
We all love those emails. It's so nice. I'm sure for you, it's patients, right? You have patients who probably come back and say, oh, you were there for the birth of my first baby. And
yeah, one of my favorite stories is actually a patient who had a very tragic first experience, and she came back and actually requested me for her second child. And that's something I will, it's like I always hold that very special. And that's, when it's faced with a tough decision of like, trying to stretch myself a little bit thinner or go a little bit further, it's like, but I want to be the person that impacts this person's life, so
nurses do that, I think, for sure.
I think but our time, I think, is coming to an end, and I want to be respectful of your time. It's really been wonderful to have you. I just wondered if there was any last remarks that you'd like to make about your book, or about, anything, what you want women to take away from where we're at right now with healthcare, or any last remarks that you might have.
Yeah, well, I just, first of all, thank you for doing the podcast and for inviting me. This has been such a privilege and a treat. So thank you for that. And I would say for women that I just think women are smart and strong, and their bodies are made to give birth. And I think, you have to believe in yourself, and surround yourself with other people who believe in you and believe in your capacity. And I think that's really important, to have that kind of support. And who those people in your life are. They're your friends and your family. But surround yourself with those people, and then believe in your ability to know what is right for you. Right? Kind of like how you, Kaylee, Callie. I'm sorry. I see your name. I'm so sorry. Like you knew that birth center was for you, right? Like you knew that. And I think a lot of women know what is in their interest, and to use that belief to then do the research that you can do to seek out a hospital with a low C-section rate. And if you can't find the rate in your state, some states it's easy. You can go to the public health department and you'll find it. Some states it's not easy, but right, you can always call the hospital and say you want to know, right? Search that out. Interview your clinician, whether it's an OB, a family physician, or a midwife, and ask them their C-section rate. Ask them their philosophy of birth. And that's totally okay for you to do. And know, and use that kind of belief in yourself and this network of people who are supporting you to go and seek the information you need to get the care that you deserve. So I think that oftentimes women are hesitant to ask for this information. Women are socialized. It's a healthy literature on this to be, we get along. Right. We get along. We don't ask, we may not need to ask a lot of questions. We want to, just be the peacemakers. And sometimes that means that we don't want to be assertive and ask questions. And I think that, give yourself permission to do that, because you need to seek information so that you can make a decision about your health care. And if anyone is ever, right, tells you that you don't have a right to ask questions or to get that information, that's a red flag.
Get out of there.
Get out of there. Yeah, because you do. And so I think that's the other thing. Support yourself with people who say you have the right to ask questions, because I think the more we ask questions, the more we surround ourselves with people who believe in us. That is also how change is made, right? Because, kind of clinicians need that kind of feedback, right? That patients have an idea about what they want. Because it's also, it's not, well, we're getting to the end. It's also that if women don't say what they want, what else can clinicians do but that's just to deliver the protocol care? Right? So it goes both ways. So I don't mean to mean women are passive when I say I talk to doctors and nurses. Women can be active, but we need to give them permission, right, in the system. And the system needs to give them permission by doing things like you're doing as a nurse, asking, what would you like? And let me tell you the evidence for this, and, kind of as you make a decision.
Yeah. I think that's really important too, that you say for women to be assertive and to ask questions, because I cannot tell you how many times I have to tell a mom to not apologize to me. She'll say, "Oh, I'm sorry, I'm doing," and I'm like, "Stop apologizing. Like, you're in late, like this is a safe place." And but I think we have this, like, we have to make it peaceful and we have to apologize if
Yeah.
we're causing, any type of anything, so I think that's really important advice that you give.
Yeah. Yeah. There's a great article by Karen Martin from the University of Michigan, and she's called Giving Birth Like a Girl. It's probably behind a paywall, but maybe I can try to send it to you. Giving Birth Like a Girl.
Okay.
And so what she finds is that, it's not just that maybe clinicians expect women to be docile and to do what they're told and to follow directions, but women themselves internalize that notion and themselves might police their behavior. So, that she found that the women in her study were apologizing to people in the room for being noisy when they had a contraction. I'm so sorry. I'm so sorry I'm being loud.
Yes.
Like, can I get you anything? Do you need any water? And she's in labor.
Yes.
But her finding was that, it wasn't kind of, it's not making fun of these women, but rather to say women are being socialized so strictly in being compliant while they're giving birth that they themselves, no one needs to tell them to do this. Right. They're doing it themselves. And I think, I saw that watching women give birth. I'm guessing you probably see this by I'm sorry for asking this. Mm-hmm. They're trying to, be compliant and be easy to get along with while they're giving birth.
Yeah.
Giving Birth Like a Girl. It's a wonderful article.
All right. Well, I'll have to look that up. But I would like to encourage every listener to go grab your books, Cut It Out and Healthcare in Crisis. They're wonderful, wonderful books. I think you'll learn a lot. And again, thank you so much for joining me today. I really appreciate you being here and taking time out of your day for us.
Oh, absolutely. Thank you for doing this. It's wonderful. I can't wait to see the film you were mentioning, and I know you have other films. So
our film, most recent film is Transmission: What's the Rush to Reassign Gender, and it's found for free on YouTube. So you
wow,
the title and watch it for free on YouTube. So, but yeah. I'd like to thank each and every listener for subscribing and tuning in. And our goal is, as ever, to create conversation, facilitate discussion, and encourage you to think beyond the masses. Thank you for joining us.